السلام عليكم. هلا راح تكون المحاضرة رقم 2 من or the passive lectures of the 7. رقم 2 من 7. We will go through it إن شاء الله today. So here we go. هلا هاي مراجعة سريعة من المحاضرة الماضية. It's put here just to show you where we're going. We're going to go through. This is basically the next few lectures. راح نحكي عنهم تقريبا هم الثلاث أو أربع محاضرات القادمين. هم راح نحكي عن all of these diseases. شو بيعمل ماكيول شو بيعمل بابيول. Instead of going in an approach where we are going through bacterial skin infections, viral skin infections, fungal skin infections, we want to go through skin infections according to the lesion that they cause. And this is the approach that has been followed by Fauci's book. So I think it's a good approach. خلينا نبلش هلا. هاي الصورة تبعت المحاضرة الماضية. فأنا بنحكي عن the infections that are associated with vesicles. So lesions or the clinical syndrome that can cause vesicular rash. عندك smallpox, chickenpox, shingles, HSV اللي هو من السورس من بين ويتلو هربس gladiatorum cold sores. راح نحكي عن hand foot and mouth disease or virus molluscum, rickettsial pox, maybe we'll not cover that, and then blistering distal dactylitis. So all of them are, as we mentioned in the previous lecture, almost every time you see a vesicular rash, you're going to think about a viral agent more than anything else. طيب بعد الفيرال agent شو استفدت أنا؟ كيف بدي what is the next step? The next step you should look at the age of the patient. طلع على عمره يعني وطلع على his or her occupation. What are they doing? يعني الطفل بالمدرسة vesicular rash. يعني one of the first things that you can think about is maybe chickenpox. An old person retired مثلا or something like that. سافر أو تعب أو صار معه شغلة عنده vesicular and dermatomal distribution, you're going to think shingles. A young adult مثلا college age has sores around their mouth or anus مثلا or genital, so you're going to think about مثلا cold sores. A guy who works مثلا بيلعب رياضة كتير contact sports where there's prolonged contact مثلا مصارعة. So you're going to think about herpes gladiatorum, hand, foot and mouth disease. You're going to think about children in a setting هو عبارة مثلا children in a مثلا in a daycare or حضانة بسموها أو مثلا إحنا شو بسميها عندنا KG مثلا هي هالأشياء هذه. or مثلا راح نحكي عنها مثلا certain مثلا occupation واحد بيشتغل مثلا ب مع animals or something like that. Mollusci also can have as well maybe more بلش مثلا in a young age, young adult and so on. So we're looking at a rash, looking at the age of the patient, and then من هدول النقطتين والثالثة مثلا شو بيشتغل شو بيعمل. I can almost have a very good point where I'm going with the patient. شو عنده شو ماله. That's a good one. خلينا نمشي فيهم هلا واحدة واحدة. Herpes simplex virus, a cutaneous manifestation of HSV infections that include شو. So what is the cutaneous manifestation? This is the viral skin infection of herpes. The cutaneous manifestations of HSV include بالبداية راح يكون المريض ما راح يبلش معه بيطلع skin infections وهذا راح يكون ال order of appearance of symptoms إنه يكون عنده أول شيء pharyngitis or gingivostomatitis. This is the most common presentation of primary HSV1. يعني قبل ما يحكي لك أنا عندي cold sores راح يكون بلا شك عنده قبل هذا cold sore أو عفوا pharyngitis اللي هو sore throat عفوا. So I have a sore throat, erythema بالماوث بشكل عام بالجنجفة اللي هو حوالين الأسنان. So that can be, and then later on, they will have, while they're having pharyngitis, they might have fever, malaise. شو هو fever ومalaise وهالأشياء مع lymphadenopathy. So these are constitutional symptoms. Any viral illness will give you fever, malaise, تعب, مثلا وجع عضلات، وجع تعب عام، ارهاق، apathy مثلا، بكون مش قرفان حاله، ما الحكي يعني. So it's all just general um, drainage of the body as the body is fighting off infection. You are using a lot of your building blocks, you're using a lot of your energy, and the virus is accumulating in the system. كل هذا بيعمل عندك الفيفر والماليز والتعب، وجع العضلات والاشياء. هلا lymphadenopathy as cervical lymphadenopathy, obviously the lymph nodes around the cervix لما بتحكي لكم عنهم I think دكتورة هبة تحكي لكم عن the lymphatic drainage of the pharynx, as the pharynx being the here the first insult. راح يكون عندي ال lymph node as they drain the pharynx, they're going to capture this virus. The virus is going to accumulate in the lymph nodes. زي ما بنعرف lymph nodes فيهم مين؟ CD4 cells, the CD8 cells. So here where the inflammation will occur, and then كل هالليمفوسايت بيجوا من انه فيروس صح. I need a CD8 ولا CD شو بدي بحتاج؟ I need a cellular adaptive immunity. So I need CD8 to work against these infected cells. So كل هذا ببلش عندك من the nearest lymph node. So you might have this difficulty chewing من يعني تفكر فيها لما يكون عندك you have a sore throat, swollen throat, you might have all of that. So then the ulcers and exudative lesions are found on the posterior pharynx and sometimes the tongue, the buccal mucosa and gums. طيب patients with eczema, هلا هاي نقطة كتير مهمة. راح يكون في عنا نقاط قليلة بالskin infections here where you have something that you must يعني make sure not to miss. Patients who have already eczema, يعني patients قبل ما يصير عندهم هذا الحكي، قبل ما يصير عندهم cutaneous manifestations of HSV, they have a history of eczema اللي هو allergic reaction on their skin, and then if they develop HSV on top of this eczema, they may have a very severe reaction, very severe disease called eczema herpeticum. Eczema herpeticum is very bad, can disseminate very quickly and may require admission and even systemic therapy لهذا المريض. that has to be captured right away. نقطة أخيرة بالهاي سلايد اللي هو that HSV has been associated with 75% cases of erythema multiforme. erythema multiforme اللي هو عبارة عن ما بعرف حطيت لكم صورة إلها هون أنا. I don't think so. yeah, erythema multiforme هاي صورتها. So this is erythema multiforme. رح نرجع لها. So erythema multiforme هي أول إشي viruses، ثاني إشي رح نحكي عنه drugs, certain هم anti-epileptics and then certain antimicrobials are the most common causes of erythema multiforme. رح نحكي عنها، رح نجيها. وين كنا؟ تمام. So 75% of erythema multiforme is caused by HSV. هلا هذا الفارنجيتس and stomatitis, as you can see, it even looks like vesicles, but because of there is no keratinization in the مثلا mucosa and the مثلا in the tongue and the gingiva, so there's no keratin. معناته ما راح تصير عندي هاي الاليفيشن زي ما بصير بالفيسيكل، فبصير الفيسيكل داخل لجوا بدل ما هي طالعه لبرا. So this is يعني it does have its very unique presentation. So in pharyngitis or stomatitis, as you can see, these are the types of vesicles that you may see. هلا الeczema herpeticum, the medical emergency that you might find, is also known as Kaposi varicilliform eruption. بيبعدوا عن هاي كابوسي لأنه بخربش مع كابوسي ساركوما اللي هي مع ال HSV8 in AIDS patients mostly. So caused by viral infection, usually with the herpes simplex virus. It is an extensive cutaneous vesicular eruption that arises again from pre-existing skin disease with مثلا أغلبه هو atopic dermatitis. So children who have atopic dermatitis, they have a higher risk of developing eczema herpeticum, in which هو ال HSV the most common pathogen. تمام. It can be very severe. It can progress to disseminated infection. شو يعني disseminated infection? It will disseminate into the system, and then راح يصير عندك كل الأشياء مثلا encephalitis وكل الأشياء اللي ممكن يعملها الفيروس بالسيستم might happen. هلا on top of that, they might have a bacterial super infection and then bacteremia, which is also another cause of mortality as well. So it is a very important thing to capture. Make sure that you never miss it, and then it's very rare, يعني, but still you have to keep it as a possible cause, especially in children. مثلا هاي الطفلة بحكي لك كان عندها these multiple grouping of punch out ulcers with local dissemination over the frontal, periorbital and perioral areas. هي هم perioral, كل هدول lesions. Turns out كانوا يعطوه يحكوا لها عندها severe dermatitis, but turns out this is eczema herpeticum, and if you look you can see here these tiny eruptions with the clearing around it. And then هذا كله bacterial super infection on top of that. So this is هلا بنجيها هاي. Okay. So this is how it looks when HSV infects the finger. عادة لما يكونوا عندهم وخاصة ممكن أطفال وحتى كبار. This is called a whitlow, where مثلا a person might suck on their finger and they have active HSV in their mouth, and they can have these severe infection, which can look very different in different scenarios. Can look يعني very large and accumulated. ممكن looks like these يعني coalesced vesicles, as you can see here, with the local erythema around it as well. So yes, this may be another. This is not eczema herpeticum. This is just whitlow. It's called مثلا. I think I'm going to talk about it further on, inshallah. So how do you diagnose? How do you know HSV عنده واحد هذا HSV ولا لا؟ بدك تعرف. Now, in the majority of cases, خلينا نحكي بال private practice أو عفوا بال general practice or in primary health care, you don't really do anything that يعني بالوقت الطبيعي يعني المريض ما معله إشي. There's no any signs of red flags. ما في red flags. أنت مش خايف على المريض. There's no symptoms other than مثلا شوية pharyngitis بعدين صار معه eruptions. Could be HSV, and then the majority of patients will overcome this. So you will have mostly clinical approach to diagnose this, but sometimes you want to know if this is HSV ولا لا. خاصة مثلا مريض عندك مريض مثلا immunocompromised, مريض تعبان, or you are suspecting something worrisome, or you have some red flags. مريض صار زي ما حكينا تعبان, يعني مريض عنده some مثلا sorts of symptoms that يعني مش زي الحالات اللي تشوفها الطبيعية. So you worry, and then you want to diagnose to make sure what you have is HSV. So one of the things that you can do it's a Zank smear. So the Zank smear اللي هو عبارة عن taking a small part of the eruptions and then looking for multinucleated giant cells. Multinucleated giant cells is a coalition of cells, يعني بتجمعوا مع بعض, they coalesce وبتحدوا بيدخلوا مع بعض and then they fuse together, and then they form this giant cell. This is characteristic for viral infections. So if you see it, then that can tell you, this is a viral infection, and most likely you will be right. But the problem is it requires a skilled observer. ايش يعني؟ بدك واحد بيعرف يقراها, بيعرف واحد يعملها, وواحد بيعرف يعمل prepare the sample. So if someone مثلا كتير junior ما بيعرف يسويها, ممكن ما يشوفها وتروح عليه. So that's one of the downsides of Zank smear. Zank smear بيطلع بامتحانات على فكرة, ديروا بالكم. مش بس امتحاناتنا, يعني امتحانات اللي برا كمان. So it requires a skilled observer to interpret, but results are immediate on examination. So what is the preparation? It's a Giemsa stain. It's basically a Giemsa stain of the blister or erosion on a glass slide. But this is basically what it is. But ما بيحكي لك إنه هذا HSV. Just tells you it's a virus, because viral illnesses will produce these multinucleated giant cells. تاني إشي ممكن تعمل direct fluorescent antibody testing, which maybe you remember from your molecular biology, is you can direct an antibody that can bind to viruses. These viruses, you wash off the remainder of the sample. If the virus is bound, معناته في عندك عفوا if the antibody is bound معناته الفيروس موجود بالsample, then you can use a secondary antibody, or you can have a primary mechanism on the primary antibody, and then you can detect it by fluorescent testing. So you can see direct fluorescence, and then you can distinguish حتى بين HSV1 ولا 2 ولا varicella ولا 3, or يعني this is very good and يعني very specific. It is also rapid and takes a few hours to prepare and have. ثالث شيء ممكن تعمله culture. How do we culture viruses? Basically, you get the prey للفيروس. مثلا هذا الفيروس بيعيش على خلايا بشرية. You grow خلايا بشرية, and then you put the sample. If these cells بصير عندك clearing حواليها, معناته الفيروس دخل وقتل هذه الخلايا, بيعمل لك clearing in your مثلا plate or something. So this can tell you what is, but المشكلة إنه you want الخلايا, بدك وقت للخلايا تنمو, وبعدين وقت للفيروس إنه ينمو. So the results are quite slow, but they are accurate and reliable. You can do multiple testing on a viral culture. منها you can do PCR. وهو صراحة إذا بدك تحكي أنا مثلا أنا عني if this is مثلا Zank smear, something that you can do in a primary setting. In a tertiary setting, your first thing you would want to go to is PCR. It's specific enough, it is very good. You can do it on the cutaneous lesion, and you can get the يعني مش كثير غالي, أرخص بضل من fluorescent antibodies. So you can do it on the cutaneous lesion, and then you can see what you have. Pathology طبعا بيقدروا يعملوا لك H&E stains, and then they can see immunohistochemistry as well. So staining with antibodies. So lots of ways to detect it. Treatment شو بدك تعمل له? So treatment هلا إذا كان only suspicion, يعني أنت فقط you suspecting عندك الhistory, ماشي إنه طفل with history with atopic dermatitis وصار معه had these severe eruptions. Only this suspicion alone warrants you using systemic antiviral agents, and they can be initiated right away. بالباقي الأمور you can use oral acyclovir مثلا in otherwise healthy patients. عادة الدوز بتكون عالية for about a 7-day course. IV acyclovir ممكن تعطي ل people who are not otherwise healthy, someone who are immune compromised تعطيهم. Foscarnet is gaining more and more ground in these kind of patients, خاصة الناس اللي يكون عندهم acyclovir resistant infection. So this is an antiviral medication which can work on herpes, بس ما بستخدمه إلا لحالات صعبة أو أصعب, لأنه it can cause nephrotoxicity. تخيل in about 50% patient, and then there's a question of mortality. So sometimes this has to be weighed later on. Valacyclovir is also good. It is ما دام تاخذ الدوز 5 مرات باليوم, تاخذه مرتين باليوم, بس هو أغلى. And then there are topical ophthalmic preparations that can be used for ophthalmic involvement. هلا الإريثيما multiforme is an acute self-limiting and at times recurring. هذه كتير مهمة. It will happen again and again and again in the same patient if the same insult happens again. إذا الانسult HSV كل ما بيطلع معه HSV رح يطلع معه the same type of rash. It is self-limiting. شو يعني بتروح لحالها. So he will get the rash over time, and then they will clear the rash. It's thought to occur due to hypersensitivity reaction in these patients, not in all patients. Again, زي ما حكينا HSV and certain medications هم anti-epileptics and antimicrobials. Erythema multiforme is a term describing target lesions. So there are circular lesions. circular lesions with a central clearing, and then sometimes with the edematous ring زي كأنها بس هدول هاي يعني هاي less typical. I see these a lot. I've seen these a lot. عادة they denote hypersensitivity reaction and more likely type 4 hypersensitivity reaction. ليش؟ HSV شو ماله ليش type 4 because this is cell mediated, so you want to اللي هو delayed hypersensitivity reaction. So there are often genital and eye ulcers and fever. and هو هلا إذا صارت إذا شفت الإريثيما multiforme and then you saw mucosal involvement, it gets upgraded. هلا it gets upgraded to something even more worrisome اللي هو Stephen Johnson syndrome. If you recall it from the previous semester, Stephen Johnson syndrome is a يعني is a disease that is يعني مش disease بتعالجه بالعيادة. عادة هدول المرضى بدخلوا على المستشفى and they have to be treated. So this is عادة it used to be called a spectrum of disease. erythema multiforme بعدين mucosal involvement بصير عندك Stephen Johnson syndrome, and then if you have a lot of detachment and bodily formation بصير هذا اسمه toxic epidermal necrosis. So this is how it used to be thought of. Now they're saying that each symptom, each syndrome عفوا is its own spectrum. فمش مع بعض مع انهم they all share the same insults, the same agents that can cause Stephen Johnson syndrome or TEN can cause erythema multiforme as well. But الفرق هنا SGS راح يكون فيها mucosal involvement, and then TEN عندك more than 30% اللي هو epidermal detachment. So that's what we're saying here. The frequently seen this is very frequently seen patients between 20 and 40 years of age with rash occurring 5 to 10 days after the viral illness. So and then persists for about a week to 2. And then the main differential هو ارتكاريا اللي هو شرية. مثلا صار معه انه مثلا اكل اشي او صار معه على جلده اشي وصار عنده شرية وانه it goes by itself, but هذا it remains for about a week or 2. So that's one of the things that you may distinguish it here. حتى بكون رح تلاقوا فيها صعوبة. يعني في شوف مرضى بضلوا عندهم فترة طويلة and then it's not thought of as erythema multiforme. بصير يقول هذا is urticarial rash يكون له different causative agents. هلا الكوزز للإريثيما multiforme idiopathic 50% idiopathic يعني ما بنعرف من شو سببه. So that's what I was just touching on. You may not know what it is. ممكن it may be called urticarial rash of some kind وما يعرف المريض شو ماله and then the management will be aimed at the inflammation. فبحاولوا يعطوه مثلا cortisol and certain and يعني similar medications to try to reduce the hypersensitivity reaction. هلا in others you will see that the HSV is more than 50% can be seen, and it occurs 10 days after acute eruption. So بصير عندهم HSV بعدين 10 days بصير عندهم erythema multiforme, which is very يعني easy to diagnose. صار معك هيك yeah, what did it look like? Yes, this and that. Okay, and then I had this kind of rash. خلاص انت you can staple the time rash انه عفوا the timeline انه عنده هذا الراش due to primary HSV. هلا other infections mycoplasma, VZV, HCV, CMV كلهم viruses or intracellular bacteria. So all of these require type 4 hypersensitivity reaction to or cellular immunity. Yes, cellular immunity to combat them. So this is where you will get your type 4 hypersensitivity reaction. So this is where it might happen. شو الأدوية حكيناهم anti epileptics and antibiotics أغلبهم sulfa drugs هذول اللي بصير فيهم. Cipro بعدين penicillin. So sulfa drugs are the most common, ciprofloxacin and penicillin, and other medications might as well happen. فأول شيء بدك تسأل anti epileptic drugs بعدين بدك تسأل antimicrobials. What do you want to do? How do you treat it? It's a hypersensitivity reaction. أي hypersensitivity أي allergic reaction, the very first thing that you want to do حكيناهم شو هو؟ You want to find the precipitating factor and remove it. إذا كان drug, you want to remove it. إذا كان HSV or mycoplasma, you want to treat it with medication. So, and then supportive care, pain medications, antihistamine, wound dressing, and then you can give antiviral medication as well. You must tell the patient if bully erupts or systemic symptoms or the mucosa becomes affected, بده المريض يرجع لك لأنه هذا معناته أنت بتخاف إنه صار معه ستيفن جونز syndrome or maybe TEN, which is an emergency. هلا ستيفن جونز syndrome يصير هذا mucosal involvement, so it is acute, life threatening, اللي هو and then it begins اللي هو يتحول من SJS to TEN. It begins with prodromal symptoms, then progresses to skill ulcerations that begin in the trunk and the face, and then typically involve the mouth and the eyes, with genitals sores as well. The patient looks يعني clinically linked to one of the causes اللي حكيناهم. المريض is toxic looking and then has a positive Nuklitsky sign اللي هو صار عنده bullous eruptions. بالمحاضرة القادمة أتوقع I will show you Nuklitsky sign. So Nuklitsky sign is a clinical sign that you can do on the skin to show إنه the skin is being detached, the epidermis is being detached from the dermis like this. So this is هاي الكيراتينized layer والsquamous epithelium, and then you have the قصة الابيديرمس بلش الدرمس فعندك this هاي هذا كل separation. This is bullous formation. This happens in TEN. So if you take a biopsy which confirms this diagnosis, يمكن بيحكي لك والله عندهم separation بالباثولوجي بورجوكم إياهم, and then clinically أنت عندك البيكتشر كمان, and this can diagnose TEN. هلا إذا TEN مش بده بكون على الورد, TEN بدك تدخله على ICU. So إذا في مالتي فورم بالعيادة SJS بالورد, TEN ICU, كلهم هذول ورا بعض as they go on. That's why I really like to think of them as a spectrum, but that's not how the current literature is moving. So ICU admission, burn units, some immune-based therapy. إذا بتطلعوا على اقرأوا شو اسمه كمان first aid تبع step 1 has some information there as well. تمام. هي اللي هم causes, هم anticonvulsants, antibiotics, anything else can cause them, some certain vaccinations, infectious diseases زي ما حكيناهم, and then other كلهم allergic reactions that may also cause these. بعد هيك اللي هو الهربس labialis هو HSV2 is the most frequent manifestation of HSV2 reactivation. More common in college students. So حكينا هذا مثلا طلاب جامعات. So 37% at year 1 college and 46 by year, يعني نصهم تقريبا by year 4 in the US have HSV2. It may be asymptomatic or present with symptoms that are milder and shorter duration than primary infection. Cold sore in about a quarter of college students. أول شيء بكون هذه يعني الهيستوري كتير بنعاد بحكي لك I have tingling at the area يعني and then later on 2-3 days later you will have these eruptions, vesicular rash, vesicles that erupt at the around the mouth, and then would resolve in about 5 days. هلا immunosuppressed patients may experience severe mucositis. Anything that you have normally in بالمرضى العاديين will have a more severe form in an immunosuppressed patient. Pathophysiology بالmouth, around the mouth, HSV1 is more than HSV2. Transmission via mucous membranes, kissing, direct contact with open skin, or sharing of formites مثلا utensils, towels, or whatever. هلا بعد الكونتاكت من يومين ل 20 يوم they may get the symptoms. However, the patient is shedding for the first 2 to 4 days. After the episode, the virus remains where tingling, كان في tingling. So there is the axons are being invaded by this virus. So the virus will شوفهم HSV1 و 2 و 3 كمان كلهم بدخلوا بيحبوا الأxons. They go in the axon and then they go up the axon to the cell body, and then they remain in the neuron, dormant in the neuron, and then they can reactivate at any time. What reactivates them is these are called triggers. You might have a trigger عادة مثلا any stress, مثلا fever, stress, sun exposure, trauma, immune suppression, hormonal changes, menses, suffer, fatigue، اللي هو هذا كله ممكن يعمل لك هذا reactivation, whether it's HSV1, HSV2 or HSV3 اللي هو الزحسر. Alright, there's something I wanted to say about, I don't remember what it was. Okay, so these are the vesicles that may happen. إذا بتعرفوا ال HSV1 is more common around the mouth, and HSV2 is more common around genital. So as an STD, both of them can be thought of as STDs. You might يعني people usually get them through sexual contact. However, HSV2 is more dominant on the genitalia. HSV1 is more dominant on the mouth. بحكي لك الأرقام are now changing slightly. إنه مثلا HSV2 is it's rising, being more on the mouth وهكذا. بس لكن لا زال HSV1 is more common on the mouth. Okay, so عادة HSV infections, the first episode أول مرة تصير معه تكون very severe, and then every subsequent episode the durations are less severe and last less time. So أول شيء بيكون عنده fever, LAP اللي هو lymph adenopathy, mouth or gingival ulcers. بعدين بصير lesions, they start itching, burn, tingling. So this is something to tie in with your anatomy. لما تحكي itch, burn, tingling, right? All these are pain sensations, right? Pain or temperature sensations. شو البين والtemperature منين بيجينا للفيس? From the trigeminal nerve. So which branch of the trigeminal supplies the mouth? So you have the mandibular branch or the third branch. So this can come up in foreign tests. تمام. Treatment بالنسبة the common HSV labialis that you can see, you can only reduce the symptom duration. You cannot remove the virus at all. There is no cure, there is treatment. So you do not cure the patient, they will always have HSV. It is lifelong. أول episode تقدر تعطيه acyclovir. هلا كمان في صار topical acyclovir as well. You can give acyclovir, reduce the lesion time to 4 days versus 10 days, and the shedding between 1 day versus 5 days. Less shedding معناته في less spreading, and it's less demanding on the patient. يعني it's not a bad idea to give it. Recurrence, same thing. Acyclovir reduce the eruption healing by time by about 2 days, and the topical by about 1 day. هلا genital herpes, most common cause of genital ulcers. 60 to 70% of sexually transmitted disease ulcers, not all sexually transmitted diseases, only the ulcers, is due to herpes. فراح تشوفوا هذا أغلب شيء يعني whoever practices in the West, you will see this very very commonly. خاصة إذا بتشتغل مثلا in a practice that is near a college. So a high prevalence in Western countries, about 12% or about 10 to 30% of sexually active people. About 300,000 cases a year in the US alone, so about 0.1% of the population each year. Caused by HSV2 حكينا أكثر من HSV1, although as we mentioned HSV1 is on the rise as a genital sore. Asymptomatic in majority of patients, so they don't have blisters or anything, they just stay asymptomatic, and that's the major mechanism of how it spread. It is shedding, but there's no symptoms, there's no blister. So the virus sheds asymptomatically. مين أكثر بيكون more likely to be asymptomatic? Females are more likely to be asymptomatic than males, and then which helps the spread even further. هلا بالعكس البكتيريال مثلا gonorrhea and chlamydia Males are more likely to be symptomatic as well. But females are also can be symptomatic there as well. Okay, so a virus sheds asymptomatically, so without outbreak, the virus can be shedding in about 10 to 20% of the days. تمام. Primary infection بالgenital herpes may be associated with fever, malaise, and adenopathy. HSV DNA migrates up the infected axon to the affected spinal cord. Here, the sensory ganglion of the spinal cord is a similar story to herpes labialis. HSV persists in the ganglion lifelong and dormant, just the same, nothing different here. On periodic reactivation, HSV DNA migrates down the axon and then erupts again, and then can cause these eruptions second and third and more times. First infection again is the worst. Vesicular eruption, similar to oral herpes, preceded by tingling, itch, and burning. Again, sensory nerves. Lesions occur in the distribution shown. Primary vesicles remain up to 2 weeks. Reactivation less time, as we mentioned. HSV genital herpes is milder, is a CAN 1 rather than 2, and has fewer outbreaks rather than HSV2. For distribution, so between males and females, around the genital area, basically in the perineum. Early stages, the blisters are clear. Later stages, they may look like pustules and have a cloudy fluid, and they may coalesce and then become slightly larger. Diagnosis, يعني ما بدها شطارة, clinical picture. So if you diagnose it right away. If it's in the, again, the same story as before, if you want to double check, if you are suspecting another illness, if you have red flags, if you are worried, you can do HSV test, PCR. As I mentioned to you, this is probably the first thing that you want to go for to get يعني specific, more specific than anything that you can get within means. Treatment. Antivirals for the primary and recurrence. Both, they do not cure but shorten the span of the illness. Again, during pregnancy, this is a very important here. This is important. During pregnancy, if هلا اختلاف إنه هنا it's a genital sore. So what happens if a pregnant lady happens to have HSV infection and active infection, so she has active lesions and now is about to give birth? So what do you worry about? You worry about a baby, susceptible baby, who is going through a canal with active lesions. So هلا كل هدول lesions راح تكسروا, كل هذا الفيروس will accumulate on the baby, and البيبي يطلع head first, right? عادة بالأغلب بيطلع الhead first. So كل هذا راح يدخل على baby's mouth and the nostril وعيونه وكل هالحكي كله, and may have encephalitis or disseminated HSV infections in these newborns, and can cause اللي هو or cause congenital HSV infection. Congenital يعني إذا this virus has ascended while the baby is forming, not while the baby is going through the birth canal. So the baby can be congenital. بيطلع هذا حكي بتعرفوا اللي راح تاخذوهم لقدام بنسموهم torch infections اللي هم toxoplasmosis. Others منها other infections R rubella, C CMV, and H اللي هو HSV. هذول are the very very worrisome viruses or bacteria or microorganisms that can cause congenital infections. فمنهم هو طبعا ال HSV اللي هو ال H بالتورش. So الأذر ممكن اللي هو مثلا treponema, syphilis, or something else. There are other ones that can all lump in the O of torch. Where are we? Okay, so congenital infections which may lead to microcephalus or hydrocephalus or chorioretinitis as well. So, hi lady and her HSV. She acquired it through college. Now she is older. Now she wants to have children. شو بدك تعمل لها? So there's يعني you have some options that you can do. Uh, Abstinence in pregnancy may work. Antivirals, luckily, they can be used and um, are not teratogenic, but has to be used under care. And there is an experimental vaccine بنعطى بحيث انه يرفع boosts the immunity for the mom. هلا الاميونيتي بترتفع and the mom can clear the virus if it sheds. So keeps her system clear. If her system is clear, keeps the baby clear. عدا عن هيك her IgG will be transmitted للbaby as well. So the baby, if the baby gets any virus, might capture it before it can cause damage. It's still experimental, and obviously I am a supporter of this يعني this approach. هلا إذا كان الأم عندها active lesions, you're not gonna let the baby go through the birth canal, so you can elect to do a cesarean section, where you تعرفوا cesarean, you can do incision through the skin and then through the uterus, and then deliver the baby through the uterus through this incision. So obviously you are bypassing the birth canal. هلا as for measures for active lesions, loose clothing. إذا كان واحد عنده active بحكي له لا تلبس أشياء ضيقة, ice packs, baking soda, oatmeal baths, أشياء كثير الناس بيستخدموها to reduce اللي هو الألم. Topical antivirus and low dose anesthetics can also be given لهدول المرضى. الوتلو حكيناها. So this is what it looks like. So HSV infection of the finger, which may result from auto-inoculation. Existing oral or genital infection بحكها أو بخرب السورز أو بكسر السورز أو بحطه إيده بتمه. So this is caused a direct inoculation from some other environmental source. And then you have vesicles with regional LAD or LAP. Differentiate from acute pyronychia, which is a bacterial infection. Treatment, prevent transmission. خليه يحط bandage عليها. Dry bandage would be enough. And then you can give antivirals in case either this is a recurrent or becomes severe, or the patient is immune compromised. You can give antivirals as well. هاي من الأشياء اللي بيستخدموها زانك سمير, and then you can see it. الهربس جلاديتورم is a mucocutaneous infection زي الوتلو, بس بيجي على الchest, على ears, على face, على hands. And this happens in contact sports, long intimate contact with patient مع بعض. So wrestlers, rugby players, where they are constantly يعني very intimate and direct contact with each other, may give whitlow in other places in the body. So this is what it looks like. هذه بدك تفرقها عن اللي هو ال HPV. HPV بيطلع اللي هم بسموها تواليل. HPV هذه مش تواليل, هذه this is whitlow. هلا أورجيكم تواليل لما نحكي عن HPV. HPV بيعمل تواليل على الجلد, and they're usually innocuous and then go on their own, but you can give cryotherapy to them and then remove them. Dermatologists usually do that. هلا البارونيكيا, this is more in females. This is due to penetrating trauma, finger biting, manicure. This is your skin flora itself. بدخل على هذا. هلا انه حكيت لكم الوتلو ممكن تكون بينه حمراء, مش زي هيك دائما. ممكن تكون very ugly and like inflamed and red. This is why one of the main differentials اللي هو البارونيكيا, لأن البارونيكيا is basically a bacterial infection, راح يكون swollen, redness, swelling, pain, وهذا الحكي كله. there might be some confusion between the two. هلا الانفكشن على فكرة وتلو كتير تيجي كمان بالامتحانات, بديروا بالكم. Infection 2 to 5 days after trauma with pain at the site and local inflammation as well. Can progress to abscess formation and nail bed infection. This is a serious thing. They might lose a part of their nail or even worse. So ما تمشيها هيك في السدين وروح. You might have to drain the abscess and so be careful. Most differentiating feature from whitlow هو basically the vesicles, if you can see them, and then history of the patient having pharyngitis or sores, mouth sores, or mucous membrane sores. This will not be something that happens in bacterial infection. Treatment, you can soak it for 15 minutes in warm water or acetic acid soak, and then drain any abscess. It's acute pyronychia, as you can see here. This abscess formation, dried abscess ما بتشوفه كتير بالوتلو. but again the picture might intersect. Treatment: topical antimicrobials مثل bacitracin, gentamicin, fluoroquinolone. You can add steroid to reduce inflammation, which quickens the healing. في كتير أنواع من الفيسيليك acid comes with a low dose steroid as well. Prolonged cases هم بدك تستخدم systemic antibiotics. شو بدك تستخدم؟ راح تستخدم الانتي ستاف ديكلوكسيسيلين سيفلوكسيسيلين مثلا سيفالكسين as first line therapy. anti-staph medication. second line اللي هو trimethoprim or doxycycline, especially if you suspect MRSA. هنا هذا اللي بخوف هنا. MRSA, your first line would be thinking, especially in the community, is this. So, you know, MRSA colonizes the nose, so a person who keeps biting their nail can easily bring MRSA into their nail bed. هلا الفاريسيلا زوستر اللي هو الهربس 3 causes chickenpox الجدري المائي. هلا 90% of cases occurs in children. This is the childhood illness. Most of the cases happen in children under the 13, and if it happens in 13 or below, it's usually يعني ما بتخوف. A peak onset is about 5 to 9 years old, although it is now being part of there is vaccination against this. هلا peak onset للchicken pox about 5 to 9 year olds, and in the cold season most of the time. Incubation من بعد 10 أيام لأسبوعين, and then transmission about respiratory droplets through direct contact, and can also be vertical through the placenta. Following incubation, the patient might have the prodrome اللي حكينا عنها, then constitutional symptoms اللي هم حكيناهم as well, and then we'll have the papulovesicular rash. So papules with vesicles, which is very itchy. This is the main problem للأطفال because it's very itchy. They're going to keep scratching it, releasing more virus and then causing more lesions. And it is the most uncomfortable symptom. So it is هون بيستخدموا له تعطيه مثلا calamine lotion or something to reduce the itching, as it is the يعني symptom that bothers them the most. This is what it looks like. I'm sure you've seen it, at least in pictures. So thing is, you have 3 phases of the pox rash. So the chicken pox rash, you have أول شيء بيطلعوا macules, tiny red bumps, and then you will have the vesicles, which may be large enough to blister, and then you will have crust. These vesicles or blisters will break, they will crust over, and then you will have a scab formation. هلا بالمريض مش كلهم بيطلعوا مع بعض, بيطلعوا in crops. أول شيء بيطلع أول زي ما تحكي أول محصول بيطلع. As it is progressing بيطلع المحصول الثاني. لما هذا بصير بالفيز 3 بيطلع المحصول الثالث. But you will see all 3 phases at the same time in the patient. This is important to differentiate chickenpox from other things. So 90% transmitted by direct contact in a household. كانوا بيعملوها كتير عنا. In England they call them pox parties. So because it became general knowledge that if you get chickenpox as an elderly, it is very severe. زي الكوفيد مثلا, كوفيد هلا severe بالكبار بالعمر, less severe بالmiddle age, and almost يعني innocuous, ما له أي تأثير على الصغار. most people at that time for chickenpox, طفل عنده chickenpox كلهم بيروحوا بيلعبوا معه, بدوا أولادهم عنده بيضلوا يلعبوا معه, آخر النهار بعد أسبوعين كلهم يصير معهم chickenpox. So it was something that was a practice that was done, مش بس لchickenpox, أشياء تانية. Should be differentiated from shingles, which is a reactivation of chickenpox. يعني واحد ولد صغير صار معه chickenpox, هذا chickenpox is an HSV. Again, it will go in the هذول البليسترز اللي بيصيروا. If it gains access to an axon, it will travel up the axon and then stay there dormant in the axon. بس بعد 10 20 30 40 سنة 50 سنة it's never gone. هاي الديرماتوما تبع الاكسون هذا, مثلا خلينا نحكي مثلا C7 or T3 or whatever dermatome, whatever lesion traveled up, see له reactivation, and then you will have a rash alongside the dermatome. بورجيكم صورة لقدام like this. مثلا هنا صار alongside the dermatome. This is a reactivation of the chickenpox. This is called varicella zoster. This is shingles, right? So this is the initial infection, chickenpox, and this is the reactivation later on. This is a young patient. This is an adult patient. So وين كنا تمام. Okay, progressing to vesicles, and then حكينا they appear in successive crops over 2 to 4 days, so the patient will have different stages at the same time. Should complications may rarely involve the mucosa or the oropharynx or the vagina. Other complications, secondary bacterial infection, pneumonitis, and encephalitis. So you still have to tell the patient, تعطيهم red signs, يعني red flag signs. مثلا تحكي ما بخوف كل شيء تمام. If you have other symptoms that progress that do not improve, ارجع لي. This is دائما احكيها للمرضاك هاي as a sort of a net. You throw a net. تحكي لهم اذا بصير معك pneumonitis or encephalitis. ما تحكي له encephalitis pneumonitis. تحكي له مثلا symptoms, neurological symptoms, or تعدد له مثلا or مثلا respiratory symptoms. وتحكي له مثلا ارجع لي اذا صار معك هيك. اذا التهبوا هذول البليسترز حط عليهم هالدواء الفلاني. And that's how you prevent any complications from escaping you. So disease may be severe in pregnancy, again, congenital varicella or pneumonia for the mother and the immunocompromised. Treatment, usually no antivirals here. Some guidelines depict oral antiviral in households that are large and immune-compromised patients. أهم شيء حكينا, you want to reduce the itch, so calamine lotion, oatmeal bath, antihistamines at bedtime. Basic tracing is بصير معهم bacterial super infections, and that's it. هلا shingles حكينا, this is the reactivation of the varicella virus. So it's called zoster, causes a unilateral vesicular eruption in dermatomal distribution. If it occurs bilaterally, it becomes it is most likely severe, and then it can be worrisome. But in the majority of patients, it's unilateral. مشكلة chickenpox was the itching. مشكلة shingles is the pain. Okay? كتير مهمة بالامتحانات. Itching بالchickenpox, pain بالshingles. So pain management here is the game. So cold in Arabic حزام ناري. In older medicine, the flame snake. بحكوا لك إذا الحية بالطب الأبقراطي إذا الحية عضت راسها البيشنت بموت. يعني إذا صار عنده bilateral and has the dermatome has crossed over to both sides, this is very severe and the patient dies. Most commonly thoracic and lumbar dermatomes would happen, although every dermatome is fair game. ممكن يصير بالhead and neck, but the dominant is thoracic and lumbar dermatomes. Again, this is a sensory nerve. راح تكون بالبداية خلال يومين وثلاثة مش tingling. هنا بلش معاه pain. What happens is that the axon becomes demyelinated. So you lose the myelin sheath on the axon, and then the axon becomes extremely pain receptors. Well, axon that sends these pain receptors or pain signals back to the spinal cord. So they become very painful. ما بروح الألم. يعني بضل هو نايم بحس بالألم, هو ماشي بحس بالألم. It is very debilitating, and خاصة بكونوا كبار بالعمر as well. هلا in the US, 300 million population about have 1 million case incidence yearly. The older age, again حكينا من 50 ل 80. 60% are females. Why? Because of menopause. Once they have menopause, this is a stress, and they may have it during that time. Pathophysiology, again, the infected dorsal root ganglion and remains dormant, typically following a varicella zoster infection. It does not go beyond the sensory nerves that intersect in the spinal cord, so it does not travel any further than that. Reactivation causes the shingles. Again, the same stresses اللي حكيناهم قبل هيك can reactivate shingles as well. هلا if a person هلا السؤال راح تنسأله أكيد is it contagious؟ Yes it is contagious. فإذا هذا العمو مع shingles he might infect others. إذا كانت مرته الكبيرة بالعمر never had chicken pox so she might get it right and might be severe. إذا كانت هي مثلا بنت أو مثلا زوجة ابنه أو بنته pregnant, so it is something that to also keep in check as well. Most commonly preceding the rash, fever, headache, numbing along the nerve root is reported. The rash then becomes erythematous, maculopapular, ما في vesicles, and then later بالبداية you will see بالنهاية عفوا you might see the clear distinct vesicles erupt. Maybe you will see it. Vesicles turn cloudy after 3 to 5 days, so it's very similar to the chicken pox, and resolution takes weeks here. So why does the resolution take weeks? Because the axon has been demyelinated, and then you have pain for about a month. So you need a whole month. So the rash starts erythematous, maculopapular, and then حكينا later on will become vesicles. You may not see that. Vesicles turn cloudy after 3 to 5 days and then cross 10 days but may leave residual scar, and resolution takes about 2 to 4 weeks. Yes, this is what we were saying. Why does it take 4 weeks? It's because the axons have been demyelinated and it takes about a month of pain for the axons to regenerate their myelin sheath, and then the pain goes away. So you want to promote here two things. You want to promote healing of the nerves, and then you want to help promote the regeneration of the myelin sheath, and then you want to reduce the pain. So you can start with the pain management other modules. I'm not going to go through pain management, but you may go up to مثلا gabapentin أو أكثر مثلا to أو يعني ممكن أكثر حتى to reduce the pain. Things that you can do to promote the healing, not much, but you can give مثلا بعض dermatologists here give shots of B12 and other vitamins to they say it helps with the healing and reduces the duration of the pain. تمام، هذا هو اللي حكيناه، ما في شيء جديد. Diagnosis. It develops 2 to 3 days after the first symptoms, lasts for weeks. Dermatomal distribution ما في شيء جديد هون. It starts proximal then distal to the dermatome. فبلش من جنب السباين ويطلع لقدام حوالين هذا، مش بالعكس. Rash is described as erythematous, maculopapular. تمام. PCR is the most sensitive and specific test that you can do to diagnose this if you are in doubt. Treatment, you can give antivirals within 3 days of the onset. Why? Because that's when the virus has replicated and caused the damage. After that, there's no virus. The problem is the nerve damage or the myelin sheath damage. That's the problem. So after 3 days يكون الفيروس خلاص راح يعني فأنت you are now dealing with the inflammation later on and the consequences of the inflammation. وين كنا؟ تمام. Pain management فبتبلش من weak to more strong. NSAIDs تعطيهم أول شيء، ممكن تعطي opioids, and then you might have refractory pain. You might give amitriptyline or gabapentin plus minus steroids and B vitamins to promote healing. هلا variants of shingles, you have zoster seniherpeti, which is zoster without a rash. فبصير عندهم pain dermatomal distribution كل إشي بدون الراش، كل القصة اللي حكيناها بس بدون الراش. هلا هاد يعني فكر فيها شوية. واحد مثلا عمره كبير بالعمر وبيحكي لك I have rash of pain on the left side of my chest وبيجي من الجنب. فيو might يعني ما تطلع انت ما في راش. So you might start thinking about lots of cardiac problems or neurological problems or مثلا عنده respiratory problems ولا. So it makes your job harder. This is rare, but it is actually on the rise. Why is it on the rise? أسباب كتير. في شيء بحكي لك إنه مثلا now we are using more vaccines. في ناس بيجي بحكي لك the variants of the virus itself and how it reactivates is different. بغض النظر, it is now on the rise. Ramsey Hunt basically is varicella zoster of the facial nerve. So شو اللي بده يصير هنا? Okay. Of the facial nerve. So what is here what do you see? It is actually a triad of facial paralysis. You might have facial paralysis. معناته أنا بطلع هنا على actually the motor neurons. فمش ما بطلع على trigeminal, أنا بطلع على facial nerve. I might have cranial nerve 8 involvement. إذا تعرفوا من الانatomy, you have them in a foramen that where nerve 8 and cranial nerve 8 and 7 are crossing together. So this is where the cranial nerve might have. So you might have ear pain, and then you have vesicles in the auditory canal or the hard palate or anterior tongue. ليش anterior 2/3 of the tongue? That's the facial nerve. بيعطي taste sensation, the anterior 2/3 of the tongue, so that can also be affected. So seen as unilateral herpetic rash of ear pinna, hearing loss may occur, peripheral facial paralysis. هدول كل هاي الترايات حكيناها. Management similar to Bell's palsy, facial nerve paralysis due to VZV reactivation, antivirals, corticosteroids, and pain killers. هلا هاي some doctors might brush this off and think of this as older patient. عندها old stroke. This is a patient with an old stroke. So عندها reactivation يا حرام على the same side that is affected by so the same side the cranial nerve here is affected. So the same side she had a stroke here. So nobody looked in her ear and can see these vesicle eruptions here. So this was actually Ramsey Hunt, and she needed antiviral therapy. Herpes ophthalmicus. So this is when the virus is dormant in the trigeminal nerve ganglion. So reactivates more in advanced age and immunocompromised, may also reactivate in systemic illness. Hutchinson's sign is typical and has a twofold risk of ocular involvement. This is Hutchinson's signs, the vesicles at the tip of the nose. This is associated with herpes zoster ophthalmicus, and this is the راح يكون على trigeminal nerve ending. So this is purely zoster sensory nerves of the distribution of the trigeminal nerve. شو ضل can cause complications, keratitis, iritis, episcleritis, visual loss. So this is scary, and it has to be managed accordingly. شو التريتمنت ودي للophthalmologist basically. That's their job. They know what to do. عادة things here, you want to give antivirals about acyclovir, see 5 times a day for about 10 days, the same thing. Valcyclovir, the same. حكينا قبل antibiotics and corticosteroid only under the ophthalmology consultant. This is where you want the ophthalmologist to be really involved. herpes كمان آخر شيء Kaposi sarcoma. So Kaposi sarcoma is associated with herpes 8, as you know. Clinical is purplish, reddish, blue or dark brown, black macules, papules and nodules all around the skin. شو راح يكون هذا؟ مريض ما راح يجيك مرة واحدة Kaposi sarcoma. This is rare. راح يكون مريض أنت بتعرفه عنده HIV. إذا شفتها هذه عند واحد, he may this is maybe the initial presentation, but it's usually not the initial presentation. This is a patient that you know has the HIV and then has these this rash. You can say this is Kaposi sarcoma, which is HHV8. It's a form of cancer. It is not in dermatomal distribution. You must suspect immunocompromised state. إذا شفته حكينا على طول لازم تفكر هذا is this Kaposi sarcoma. ما عدا هذا البيشنت كان عنده HIV and maybe he did not know. That happens. شو المريض بيجيبوا لك اياه عادة بحبوا يجيبوا لك مرضى drug abusers، او يجيبوا لك مثلا بالغرب يعني drug abusers homeless. ما راح يجي واحد بالاربعينات هيك بتاخر الثلاثينات بالاربعينات انه كاين معه اتش اي في، ما كان يعرف، ما مش داير باله على حاله، and then he presented with Kaposi. He presented with مثلا toxoplasma بالبرين. He presented with cryptococcus meningitis. He presented with كل هدول الامراض infections that can occur in full blown AIDS. So any of these infections might be the initial presentation. Cryptococcus كتير مهمة، toxoplasma البرين، رقم 3 اللي هو الكابوسي sarcoma. These are one of the three main things that you can, as well as fungal skin infections. وعدا عن بقية infections that can happen in an HIV patient. بكرة لما تروحوا على مثلا الباطني بكم هذا something that you want to also look at. بنخلص هون هيك المحاضرة الثانية vesicular rashes. I think we have a little bit left of vesicular rashes المحاضرة القادمة. Then we start with the other form of infectious rashes. ويعطيكم العافية.